Good afternoon and good evening to all of you, and for those watching from abroad, good evening and good early, very early morning, given the time difference. Welcome to our Vascular Ultrasound Master Class today. We're going to be talking about lower extremity arterial exams. We're going to cover both physiologic and arterial duplex examination. We're going to talk about different ways in which we interpret these exams, and specifically how to really read the language of the waveforms. I believe that there's two components. It's almost like a book. There's the technical part, which is the numerical values, but then there's also the words and the meaning of those words, and those words are represented to us by waveforms. And I think this is something very important that I'd like to get across as a very strong message. We shouldn't focus only on the numbers, but also on the waveforms, the appearance, the morphology, the phasicity of a waveform, or the pulsatility of a waveform, their resistance, and their overall appearance within the context of a clinical case or a patient. So we're going to start with this. We have a lot of material to cover. Hopefully we'll be able to cover everything within the hour, and we'll also have questions at the end, and we'll try to address as many as we can. So let's go ahead and get started. So peripheral arterial duplex exam. First of all, we need to be able to know what to document. And when we look at arteries, we need to look at the long axis in grayscale, and also look at Doppler images. And at a minimum, we need to document common femoral artery, superficial femoral artery, proximal profunda, popliteal artery, and the tibial vessels when necessary. But these, we're talking about what the minimum is. And we need to look at the aorta and the common and external iliac arteries when necessary or appropriate. We need to look at arteries in grayscale. We need to look at color. We need to also evaluate Doppler waveforms and velocities. When we have bypass grafts, we need to also look at the proximal and distal anastomosis of a bypass graft, and also at its mid-segment. And if it's a venous bypass graft, certainly we have to be very meticulous about looking for any areas of intragraft stenosis. For stents, always look at the segment before the stent, at the stent, within the stent, and also in the distal segments. Any abnormalities require additional images, waveform measurements, and velocity measurements. Spectral Doppler waveforms are also important, and velocity measurements are also important. Just like looking at the image itself, at the vessel itself, we also need to document spectral Doppler waveforms and velocities in the common femoral, superficial femoral, profunda, popliteal artery, and tibial arteries. Again, the aorta and the external iliac arteries when appropriate. Sometimes these are, the latter ones are designed to be looked at as a separate examination when indicated. Like I mentioned earlier, for bypass grafts when present, we need to include the proximal and distal anastomoses, and also the inflow and the outflow arteries. If you have a venous bypass, you really want to make sure that you look at the vein graft in detail to look for any areas of intragraft stenosis, especially at the valve cusps or segments. When we look at stents, again, we got to look at the proximal native artery, at the area of the proximal stent, and also in the mid and distal stent segments, as well as at the distal segment of the stent and the outflow artery. When we look at physiologic exams, and these are the non-invasive physiologic tests and so forth, we need to evaluate multiple levels, unless you're doing just a plain old-fashioned ankle brachial index. If we're doing a physiologic exam of the leg, we call it in our institution a complete physiologic exam. We have to look at the common femoral, popliteal, distal tibial vessels, and any supplemental documentation as needed. We also tend to include the toe waveforms and indices too. So let's start with the real work of arterial examination. First, we need to understand what an arterial waveform in the lower extremity. Remember, lower extremity, unlike the carotids, which we've talked before, are essentially a high resistance system. Why? Because the arteries supply muscles, which are a high resistance, unlike the brain, unlike the internal carotid artery, which is a low resistant waveform. Lower extremities and upper extremity waveforms are high resistance. So as such, we're going to have, I would call it, three peaks or three spikes: a peak systolic antegrade flow, a reverse or retrograde diastolic flow, and a third forward diastolic flow. This is called a triphasic waveform. This waveform in any form or fashion needs to be ingrained in our heads because it is the basis of our interpretation and the understanding of arterial exams. Any deviation from this should raise concerns that there is something going on. Either we're interrogating the artery at a wrong angle or there's particular disease present. So let's start with the easy part. Let's start with the physiologic studies. As you can see here, waveforms are essentially triphasic. You may argue that the posterior tibial artery is not really triphasic, it's more biphasic, but trust me, this is a normal exam. You have normal ankle-brachial indices, you have normal waveforms throughout, and the toe indices are also normal and the toe pressures are normal. Here's another normal exam, and notice how the waveforms do tend to vary a little bit from patient to patient, and even within the same patient the waveforms vary. But remember, here you have a gain of 40 in the posterior tibial and the anterior tibial, but here the gain is 100. So the waveforms are a little bit different in magnitude or size, but if you notice, they remain triphasic, okay? And that's the importance. Again, ankle brachial indices are normal, toe brachial indices are normal. And how do we get the ankle brachial index? For those who are new to ultrasound or physiologic tests, you get the highest brachial pressure, and you also take the ankle pressure, and you divide the ankle pressure by the brachial pressure, and that will give you the ankle brachial index for each segment, for the posterior tibial, anterior tibial vessels, or in this case the dorsalis pedis, which we will detect at the dorsum of the foot for both lower legs. So this is important. You have to know what an ankle brachial index means within normal vessels or non-calcified arterial walls that are actually compressible. When you have arteries that are super calcified, especially in long-standing diabetics, you can't compress the artery. The artery is tight enough that all you have is a pipe that's circulating blood flow. And so these measurements have to be considered within that context. Okay, I'm not going to go over each range, but anything over 1 essentially is normal. Anything below that, you start carrying risks. Anything below 40 or 0.4 is certainly in the severe range. In a similar fashion, there's certain established indices for the toe brachial indices, and these are listed as you see. So let's start looking at the right leg. First, I like to always look at what do I expect. Do I expect to see a normal vessel, what a normal vessel looks like? And then I look at what I'm seeing, and is that within the expectation? So normally, I would normally expect to see a normal vessel. So here, essentially, we have almost a normal vessel. We tend to lose the antegrade diastolic flow slightly. So this is a biphasic, more likely almost triphasic waveform. I don't see a lot of significant disease, noting that there's always a segment of variability depending on how we interrogate that vessel. But the ankle brachial index on the right side is in the normal range, just in the lower limits of normal. The toe brachial index is also within normal. On the left side, you notice the waveform has just suddenly changed. It's a biphasic waveform. And that is consistent with also the findings that we see on our ABI. Our ABI is also decreased. The dorsalis pedis or anterior tibial vessel here, it could potentially be almost a biphasic as opposed to a monophasic waveform like it looks up top. But there's a slight morphological change or a significant morphological change compared to the right side. So we know that there's disease on the left side. That's also confirmed by the right at the lower end of the mild range in the toe brachial index. Again, let's look at this exam on the right side. Essentially, it's a normal exam, okay? Ankle brachial indices are as expected within normal and within the expected normal range. So are the toe brachial indices. Let's look at the other exam here. We look at the waveforms on the right side. Definitely, these are not normal waveforms. There's certainly disease. The ankle brachial index is in the severe or ischemic range. The toe brachial index, essentially, it's almost 0. So there's significant disease on the right side. On the left side, you start to look at the waveforms. The posterior tibial waveforms are almost normal. It's right at the edge of the mild range. And the dorsalis pedis or anterior tibial waveforms are almost normal, but the brachial index is slightly decreased. So the question is that a correct brachial index for the anterior tibial, or are we suspecting with almost normal tibial waveforms where there's some more proximal disease above the tibial segment? But certainly you can see the difference between almost normal to normal and significant disease on that same patient. Here, the waveform morphology, it kind of loses. It almost looks like I mean, I like to kind of compare it to something visual, almost like a VTAC segment. And I consider these almost hyperdynamic waveforms. If you look at the toe waveforms, they're almost completely absent. And this patient is on vasopressors, sedated, on mechanical ventilation. And the digital waveforms are essentially significantly dampened, considering the fact that there's adequate, almost perfusion, as we see up top. And this patient is on significant vasopressors that's having distal peripheral vasoconstriction. And we're going to give some examples of what shock would look like and how shock improves when it's resolved. Here's some other waveforms that look to me, I will call these hyperdynamic, on the patient who's tachycardic, who's almost in shock and has increased cardiac output, etc. Once again, here we see a patient. Waveforms are normalish on the right side. And again, it's, you know, can you see a biphasic or a triphasic waveform? Sometimes you could kind of call it each way, but in general, it looks normal. Now, the toe waveforms are slightly dampened and the indices are low. So this patient had distal small vessel disease. What did we do for this patient? We placed the patient on cilostazol for 6 months and repeated the physiologic study. You see the appearance of the waveform somewhat improved, and also the toe indices also improved. It became normal on the left and they're on both legs, on both feet. So that was a significant improvement on 6 months of cilostazol, which is a phosphodiesterase inhibitor and helps improve distal vasoconstriction. Again, here you have normal waveforms. These are definitely triphasic. Can't argue about that. But the ankle brachial indices are decreased. They're in the mild to moderate range on the right, and then they're on the mild range on the left. So the only time we're going to see distal normal waveforms with decreased ABIs is if there's a more proximal stenosis. Now, if it's bilateral, it's either aortic or bilateral iliac or somewhere in between, anything above the tibial. Of interest, this patient had bilateral popliteal artery stents placed, and, you know, as we see, the physiologic study shows that there is some evidence of restriction of flow at the end, but distal perfusion is maintained with normal toe brachial indices. Again, I look at the normal first. Normal left, perfect. Right side, there's definitely disease here. And then this could be either purely tibial disease or an occlusion of the popliteal artery or any segment above. And there's definitely evidence of ischemia, as the toe indices essentially are zero because there's no toe waveforms detected. Again, this is almost normal waveforms. I mean, with a waveform like this, I would expect an ABI to be closer to the normal, especially because the waveforms are very similar bilaterally. But if you note the ABI, the ankle brachial index on the right side, and also the toe index is decreased. So again, just like this previous patient, well, not that one, these previous patient here, I'm suspicious about an inflow stenosis, above the tibials, popliteal, SFA, common femoral, common iliac, but somewhere on that segment because the left leg has similar waveforms, normal ABIs. Here, what do we see? Look at this waveform. You look at all the waveforms. These waveforms, patient is a little hyperdynamic, probably, but, well, not going to say that, tachycardic, but there's reversal of flow in the posterior tibial artery here, okay? This is the reversal of flow in the posterior tibial artery. There are biphasic waveforms in the anterior tibial dorsalis pedis, monophasic waveforms, certainly in the dorsalis pedis. If you look closer, you may see a little biphasic form, but it's mostly monophasic. But this is consistent. This is consistent, again, with the waveforms match the ABI, and that's the key thing. Do these two data points, the waveform that you're interpreting and the ankle brachial index, match? Again, there's more reverse flow. Here's another example. Reverse flow in the left dorsalis pedis. Now you see here, there's some calcification in the dorsalis pedis. You cannot calculate an ankle brachial index because the pressure is too high. Well, artery is calcified, is occluded at some point, and what you see is distal reconstitution through retrograde flow. So the data meets the numbers. Here again, right side, definitely. The ankle brachial indices are in the moderate to severe range, okay? Waveforms are consistent. Left dorsalis pedis waveform shows a little bit of almost a biphasic waveform, but then what do we see in the posterior tibial? The waveform, is reversed. And we correlate that with the arterial duplex exam, Okay, so this is the left mid posterior tibial artery, and at the distal posterior tibial artery, you see reversal of flow. So you know that there's a segment of occlusion anywhere above the ankle where this measurement was taken, and it's anywhere between the mid to distal segment. But the physiologic study correlates exactly with the duplex ultrasound. Once again, on the right side, the waveforms, you know, the gain is 25. I would like to see a gain of 50 or 75 or maybe 100 here so you can really appreciate the different phases of the waveform. I suspect this waveform will be triphasic. Again here, the left anterior tibial at the mid segment is completely triphasic, but distally at the dorsalis pedis, you see that the waveforms become completely monophasic and low resistance. So we know that, you know, the left, probably distal anterior tibial artery has a significant area of stenosis, and you see, as we see it here, and that's reflected on the dorsalis pedis that has decreased waveforms and flow. Now, let's look at this. What do we see here? We see normal waveforms in the dorsalis pedis on both legs. Okay, means anterior tibial there is open. Posterior tibial, well, the waveforms are a little bit different. Decreased amplitude, decreased, their phasicity has changed. And this is consistent with an ABI that is decreased. It's in the mild range, potentially maybe slightly falsely elevated, but we'll see. We'll look at this waveform, posterior tibial. That's definitely an abnormal waveform, monophasic waveform, but the ABI is normal, 1.11. Well, that is falsely elevated. We know then that the posterior tibial artery is calcified, it's stiff, it's poorly compressible, and this is why we see the ABI. We can't call this normal because the ABI is normal. We call this is an abnormal waveform. So flow is normal through the anterior tibial, and the patient here has essentially posterior tibial disease bilaterally more significant on the left compared to the right side. Once again, we see these waveforms are not normal. On the right side, the ankle brachial index sort of correlates, it's diminished, consistent with the appearance of the waveforms. On the left side, it's almost normal. Well, is that consistent with the appearance of the waveforms? Absolutely not. And I would call this, falsely elevated ABI on the left side, and due to calcified, non-compressible, poorly compressible tibial arteries. I wouldn't say non-compressible in this case because we're compressing, but they're poorly compressible. Once again, let's take a look. Left side, because I see the right side, not so normal. Left side is normal, essentially. I'm looking at the waveforms are normal, triphasic, normal indices, normal toe indices. Perfect. On the right side, we see that the common femoral waveform is not symmetric. There's an abnormality there, and we go straight down, and there's an abnormality. The ankle brachial indices are definitely diminished, and as is the toe brachial index. Here, I'm suspicious about a right iliac artery, stenosis, disease, etc. And something significant because it has contributed to a massive decrease or a significant decrease in the ABI from normal to the moderate range. Again, another patient, similar, we look at the left common femoral artery waveforms, they're triphasic. The right side, they're not triphasic. We know for sure that there is disease, inflow disease on that right side. Starts with iliac disease. And as we go down, we notice how the waveforms start to change. If the waveforms remain normal throughout or very similar to the more proximal femoral, we would say it's only, there's only disease. But here we see that this is normal, and then we see that there's some superficial femoral disease that translate into maybe popliteal disease, not so much, but definitely tibial disease. Because these waveforms, if there was no disease between the femoral popliteal segment, the anterior tibial segments would remain the same. But we know that here there is disease in the anterior tibial segment, maybe in the superficial femoral segment. Here, waveforms kind of translate symmetrically. So I don't see a lot of disease until I get to the also dorsalis pedis. So on the right side, we can claim there's iliac inflow disease and dorsalis pedis disease. Or anterior tibial disease in that case, which is kind of the vessel that supplies the dorsalis pedis. Here, we look at the peripheral waveforms. Superficial femoral, popliteal, and tibial vessels. Waveforms are triphasic. So you say, okay, great, there's not a lot of disease in these vessels, okay? These vessels, I can say, they are normal. But what we're looking at is the ankle brachial indices are significantly decreased. They're in the moderate range on both sides. And how can you have normal waveform with moderate range? Well, because you have more proximal inflow disease. And if you look at this, you see, and that was that patient, okay? We see that there is inflow disease right here at the superficial femoral and femoral vessel, and probably iliac disease up top. Sorry, wrong slide. So again, we go from normal popliteal and tibial vessels, almost triphasic, and then we look at the fact that there is some inflow iliac disease bilaterally, and probably some proximal superficial femoral disease. But here, the key thing is inflow iliac disease. And because the common femoral waveforms are abnormal, I would suggest that this patient has more likely external iliac disease, more so than common femoral artery disease. Again, another test. Left side, waveforms are normal. I don't even care about what the ABI says. The waveforms are normal in this case, so that's important. Then I look at the ABI. So I always look at the ABI first, and then I look at the waveforms. Waveforms are normal. I don't expect much disease. I look at the ABIs. If my ABI is normal, we're good to go. If the ABI is abnormal, I have to think why. And if the tibial waveforms are normal with an abnormal ABI, then disease is more proximal. On the left side, there's definitely evidence of disease. Posterior tibial waveforms are not normal. Dorsalis pedis waveforms are not normal. I know there's tibial disease there, or inflow disease with a normal ABI. I know that the vessels are calcified, poorly compressible. Can't trust the ABI. I have to trust my waveform read, and I know that there's disease there, and that's also confirmed by decreased distal perfusion of the toes, where the toe brachial index is in the mild range. This is a patient with a right below the knee amputation. We see that normal femoral and superficial femoral waveforms with abnormal popliteal waveforms expected, not a big deal. But we look at the left side. What's going on? The waveforms are normal. I'm already thinking there's iliac inflow disease in this patient, and that's translating throughout, and then patient definitely has tibial artery disease with poor toe perfusion. So here we know that there is proximal inflow disease, and as the waveforms change slightly in appearance and become less symmetric in the tibial vessels when we compare them with the more proximal vessels, there's also evidence of tibial artery disease. Let's keep going. What do we look at here? We have common femoral waveforms are normal. Femoral waveforms are normal. Popliteal waveforms are normal. Tibial waveforms, they change a little bit. There's a little abnormality there, okay? They lose that kind of obvious phasicity there. And the toe brachial indices are in the mild range. So what we see here is that patients essentially have tibial artery occlusive disease, okay, that has changed the waveform morphology and has contributed to a decrease in the ABIs and the toe perfusion. Here's again another patient, normal, almost normal waveforms here with a decreased ABIs in the mild range. Here I'm thinking there's more proximal inflow disease. If it's bilateral, you start thinking iliacs, femorals, superficial femorals, popliteals. But there's certainly some disease, not that significant. Again, normal triphasic waveforms throughout until we get to the dorsalis pedis waveform. Definitely anterior tibial disease. Here, normal waveforms throughout until you get to the tibial vessels, and there's tibial vessel disease in both lower legs. Again, triphasic waveforms on the left, essentially. On the right side, there's biphasic to monophasic waveforms with a decrease in the ABI. Dorsalis pedis is occluded, and there's no toe perfusion. So this patient has significant disease on the right side. Could be tibial, could be more proximal. You know, it's not unusual to see this with a patient who's embolized, let's say, to the popliteal artery, and then they have significant compromise in flow distally. Okay. Again, almost normal waveforms on the right side, normal ABI. Toe indices are normal, left side disease, and there's either more proximal disease or occlusion within the left leg. So this is one of the tests I kind of mentioned earlier. So this patient had come into the hospital, had a normal baseline physiologic study from a couple years ago. Okay, she came in with rhabdomyolysis and shock, and you look at the waveform, slightly hyperdynamic, and the ankle brachial indices were decreased, consistent with the appearance of the waveform, and also the toe indices were sharply decreased. I mean, we really couldn't get any significant toe waveforms. Shock improved, distal perfusion improved, cyanosis improved. 4 days later, we obtained another physiologic study, just a limited version of it, and waveforms went back to almost normal as she was at her baseline. And toe perfusion improved remarkably. So this is super important. Now let's switch to duplex studies. So again, when we compare velocities at a stenosis, we compare the velocity right before the stenosis, a couple centimeters before, to the area of stenosis. You divide the peak systolic velocity at the area of maximal stenosis, which is going to be turbulent flow, elevated velocities, etc., divided by the more proximal, and then you're going to get your ratios. And the ratios that we use at our institution are as follows. Velocities less than 40 in a venous bypass graft suggest impending failure. You should know this. Intrastent stenosis within the SFA, the numbers change from the native vessel, and we look at more than 80% stenosis if there's a peak systolic velocity, more than 275 with a ratio of 3.5 or greater. Iliac artery stent, different from the peripheral stent. It's more than 50% stenosis if the velocities are more than 300 and the ratio is more than 2. So let's start again. What we see here is a normal waveform. Peak systolic flow, reverse diastolic flow, antegrade diastolic flow. Things are happy. You see the difference in the peak systolic velocity. There's a little bit of an arrhythmia or an early contraction here. And what happens is the heart has not had enough time to fill, and that's why the peak systolic velocity is lower. As the heart has more time to fill, it's able to get more flow out. Peak systolic velocity improves or increases. By the way, when you take a measurement and you want to document the peak systolic velocity, you want to get the highest number. And also the more consistent. So ideally, the peaks that would be more consistent would be this, as this beat is early, and then you get a little bit of time to fill, and so on. Again, so let's look at waveforms. I'm not going to look at peak systolic velocities at this point. I'm just going to look at waveforms. And by looking at the waveforms, I know what's going on. Right side is normal, triphasic. Left side is abnormal. It's monophasic. We know there's right iliac artery left iliac artery inflow, significant disease or occlusion. I don't care what the peak systolic velocity is at this point. I know that that is an occlusion or a significant stenosis, and there's a disease there, just by looking at the waveforms. Of course, we have to look at the velocities, but that's sort of besides the point at this time. Again, I always look, I try to see, can I find a normal? So left side normal, peak systolic velocity, this is a peak in systole, reverse diastole, antegrade diastole, triphasic, monophasic here. So again, inflow stenosis in the right iliac. And just so that you can see that this is a continuous sort of example here, this is biphasic or triphasic waveform here. And then again here, this is monophasic, low resistance waveform. You see that? Long, it looks almost like an internal carotid artery waveform, okay? Or a vertebral waveform in a way. So we know that there's a significant stenosis and the patient is significantly vasodilated, and this is what we're seeing. A lot of times we tend to see this when you have collaterals and there's a more proximal occlusion. Again, right side, monophasic, low resistance. Left side, it's almost a biphasic, a little disturbance. You know that there's some adjacent disease here. In this case, I start looking now when I see a little disturbance of flow, when I look at the velocity, it's maybe within the higher range. But certainly there's more significant disease on the right side. Again, let's look at this. Left side, completely normal. Triphasic, ABIs are normal, and toe indices are normal, perfect. Right side, you see the waveforms? They translate. They're symmetric, monophasic. Let's look at that same patient's arterial duplex. Common femoral artery, monophasic waveforms. Where's the problem? Right iliac artery, significant disease or occlusion, okay? Simple. And now you start to put the physiologic study with the arterial duplex, and the more you see these things together, you're going to be able to read this ultrasound, this physiologic study, with almost the intuitive sense of having seen the duplex. Again, here we go. Peak systolic velocities are elevated, almost biphasic waveform, some low resistance, but very sharp upstroke. Note these waveforms here. The upstroke is not, you lose some of that peak systolic rise. It becomes a little rounded. So to me, this is maybe a more proximal significant stenosis or occlusion, but much more proximal. Here, the patient, you see a very sharp rise. So I know that the disease is probably more, it's more adjacent to the segment. Now remember also, here we're measuring even though it says 6 degrees, the vessel is almost coming at you. The external iliac artery is coming up from the pelvis over Cooper's ligament. So again, there's some morphological change by just the angle of insonation. On the left side, the left external iliac, measured similarly, has a more normal looking appearance. What do we see here? Left external iliac artery, staccato. Essentially, there's no diastolic component. That's a staccato waveform, okay? And then what do we see here? For waveform almost reconstitutes, some disturbance of flow. That means that between the external iliac and the left proximal common femoral artery, there's a significant stenosis that's leading us to see this. Again, this is the left external iliac, left common femoral artery. Again, so let's see what happens with certain waveforms and how can we interpret what we see. Common femoral artery, biphasic. Maybe if we dial our knobs a little bit, we may be able to see that triphasic nature. Maybe, maybe not. We'll see. But you see, the waveform doesn't have a lot of spectral broadening. As we're going down the left SFA, we start to see still biphasic waveform for sure, with some spectral broadening. We lose the reverse diastolic component. We can't see it very well. Okay? And then the waveform becomes almost monophasic. And then here you see tardus parvus. So what we know here is, without looking at the waveforms, at the velocities, that we see that between the left SFA and the distal, the left popliteal artery, there's an area of significant stenosis where you see more high resistance flow. Okay, the magnitude of the waveform starts to come down, almost like a staccato-ish appearance, but not quite so. And then you see tardus parvus, low resistance waveforms. And here we don't have any area of significant elevation. Maybe the stenosis was missed. Again, it's sometimes a little bit hard to insonate right behind the knee in the distal femur, but based on the waveforms, you know that there's an area of stenosis there, probably at Hunter's Canal. So this is sort of how we tabulate the different velocities that we see on the study and how we tend to document some of our reads. But again, let's take a look at the same patient that's tabulated up here, and we see tibial peroneal trunk, high resistance waveform in the tibial peroneal trunk. In the distal tibial peroneal trunk, we see increased velocities. Okay? So here the peak systolic is about 50 or so. Here our peak systolic is 140. And then distal, okay, distal to this segment, you see monophasic waveform. So we know that there's a significant stenosis here. And this 140 divided by, in this case, 74, it's almost a ratio close to 2. So less than 50% stenosis, but maybe more significant than that, giving the significant decrease in the waveform morphology, velocities, significant low resistance waveform with decreased systolic rise. It's almost like a rounded waveform. Again, there's the proximal AT and the distal AT. What do we know? Well, here's a picture. Mid-AT is occluded. So between the proximal AT, normal, almost normal waveforms, to the distal AT, you see reconstitution. And these are low resistance waveforms that we're able to see. Again, another patient, normal posterior tibial, normal anterior tibial dorsalis pedis, some abnormality in the distal posterior tibial artery on the left, but there's reverse flow in the dorsalis pedis on the right side. And then what we see on the right side is anterior tibial is open. The distal anterior tibial is very high resistance. It's also antegrade. So the area of stenosis here will be where? Between the, almost at the ankle, just proximal to that dorsalis pedis vessel that you're trying to insonate. Okay? This is a nice picture of a distal anastomosis. This is a vein graft, and it goes into the distal anastomosis. And then at the toe, you have 250 centimeters per second velocity. I did not take on the more proximal segment to document or get the ratio for stenosis for this picture, but we know that there's an area of stenosis. You can see it. You can see the color flow disturbance. You see the spectral broadening here. You lose some of that reverse diastolic flow here, and velocities are elevated, certainly at that area. Here's another example. There's a drop in velocity in the shape of the waveform as we progress down the SFA. So this is the proximal SFA. Mid SFA, you see high resistance waveforms because you don't see a diastolic component. So there's probably an area of severe stenosis or occlusion. And then this is adjacent, so the stenosis or occlusion will be where my cursor is. Okay? There's some reconstitution of flow, and then there's significant distal SFA waveform, low velocity waveforms, monophasic waveforms, low resistance waveforms. Again, common femoral artery distally, area of severe stenosis, high resistance, spectral broadening, high velocities, 337, more proximal, you have 64. If you divide these, you're going to get a high ratio. And then distal to this segment, you see a sort of a waveform that is low amplitude, monophasic in nature. Again, another example. There's a patient with an SFA stent, and if you see, I don't know if it projects well, but the stent starts right where my cursor is. Up here, normal vessel, the stent starts there. So right at the inflow of the stent, you have significantly disturbed high velocity waveforms, 594. You already know just by looking at the waveform that there's an area of the stenosis. There's spectral color changes. And then distal to that segment, the waveform starts to try to reconstitute, and more distal to the outflow, you see a well-formed, low, monophasic, almost tardus parvus waveform. Again, so that we don't forget what happens, same patient, okay? Remember, we're talking about the left side. Right side, normal triphasic waveforms, maybe slight decrease in the ABI on the right dorsalis pedis, but perfusion remains. On the left side, you see the tibial waveforms. They're almost monophasic, or maybe some biphasic form if we increase the amplitude. But the physiologic study shows decreased ABIs within the moderate range, and toe perfusion is also decreased. Again, here you see the distal SFA and the proximal popliteal artery. Waveforms are not what you expect. They're definitely dampened, low velocity, decreased systolic rise, etc., monophasic waveforms. There's definitely a stenosis between the distal SFA and the popliteal artery. Again, here's another area of stenosis at the origin of the SFA. So you look at it without color, and you can see a sort of a plaque sort of rising, almost like a little valve. You see color flow disturbance, you see the stenosis, you measure, you see high velocities, and of course you want to measure the more proximal segment, but here I'm trying to illustrate the stenosis per se. This is a patient who had a left femoral endarterectomy, okay? And then as we move through that, there's an SFA proximal stent, high resistance waveforms in the proximal stent, almost monophasic or staccato-like waveforms. And then you hit the area of stenosis. So you go before the stenosis, you see this. At the stenosis, disturbed, high velocity flow, 547. And then at the outflow of the stent, you see these sort of monophasic dampened waveforms. This is a patient with a femoral anterior tibial artery bypass, and you see this intraluminal thickening or debris, and then this is the luminal flow. And what that is the bypass is usually 6 millimeters. And as the bypass goes to a smaller vessel, it tends over time to fill itself with sort of chronic material. If you open it up, it's more like this gelatin that fills up, because the outflow will start to restrict itself to meet the actual vessel outflow that is at the outflow of that bypass. So if the vessel is 3 millimeters, I would expect this channel, as we get down towards the end of the bypass, to be almost 3 millimeters if you go end to end in a way, or end to side. And here you see the distal anastomosis. You see here almost at the heel, or the, I'm not sure, probably right at the distal anastomosis. And here you see that there's a little bit of high resistance waveform as we look at it. And again, you're going to expect that because you have a 6 millimeter graft going into a smaller vessel. This is a patient with a femoral tibial artery bypass, and don't be fooled, okay? This is the bypass coming down this way. At the toe, the waveforms are antegrade. At the heel, as flow goes retrograde, the flow is retrograde. And we're doing a femoral tibial bypass because there's probably more proximal occlusion. So the bypass is actually supplying antegrade flow as it's supposed to, and retrograde flow, as this is an end-to-side bypass. And again, you know, you would expect antegrade flow and retrograde flow. And again, this is what we see. There's a little disturbance in flow as you have a big conduit going to a smaller vessel, but velocities are not elevated. And again, here we still have almost a triphasic waveform. Again, here there's a femoral popliteal artery bypass. Actually, this is actually pretty cool. You have the bypass graft as it goes down, and you start seeing here that there's a little bit, I mean, these waveforms, when I see this, reminds me almost of pseudoaneurysm, but it's not. Okay, so here what I have is the bypass, femoral popliteal artery bypass, and then you have the anterior tibial artery, which we see here, the proximal anterior tibial artery, and here we see the tibial peroneal trunk waveforms. And if you see the tibial peroneal trunk waveforms, this will remind you almost of vertebral steel, where you have almost reversal here in the systolic flow. Where would that stenosis be? And the stenosis would be right there at the origin of the tibial peroneal trunk. Why? Because you have antegrade flow going the anterior tibial artery, and to have reverse flow in the tibial peroneal trunk, you're going to have a occlusion, essentially, at that segment. So flow is coming through collaterals and filling the TP trunk retrograde. Here there's a severe left popliteal artery stenosis. You see that significant stenosis there. Velocity is 547. In the more proximal segment, you see a little bit of a high resistance waveform there as it's hitting. So this is proximal, this is the stenosis. The high resistance waveform is hitting the area of stenosis. That's why you lose the diastolic low resistance component, and you have a more than 75% stenosis as the ratio is 6. Again, this is a proximal SFA. This is an area of before the area of stenosis. You see how the waveform starts to change. It starts to get a little more disturbance of flow. Spectral broadening, colored flow disturbance. And then after the stenosis, it's almost like things quiet down. Velocities calm down, low resistance waveforms start to come up. Again, staccato waveform, tardos parvus, low resistance, further down. Okay? And this is showing you that the patient is maximally or significantly vasodilated distally. So one quick thing, every time you see staccato waveform, you have to think outflow occlusion or significant stenosis, but mostly occlusion. Okay, let's see. Here's a patient with a proximal SFA stent occlusion. Okay, so let's walk through this. Here's the common femoral artery proximally on the left, and then the distal common femoral artery. You start seeing a little bit of spectral broadening here. Okay, and then as we're moving down, as you get towards the area of the stent, you see some disturbance of flow, but then as you get at the outflow of the stent, you see almost this tardos parvus waveform, and this is in the distal SFA. So we know that the very proximal SFA is patent, okay, and as you get into the stent that's in the proximal SFA outside the outflow, likely at a segment past the collateral or so, you start seeing that it's occluded, and you see the tardos parvus waveforms distally. Let's talk about various pathologies. There's a patient with an iliac artery stent, and you see here there's flow outside the stent. So the stent is not completely opposed to the vessel wall, so it's probably undersized. Again, this is just a picture of a stent, how it would look like, okay, and it carries its area. This is the proximal area of the stent. Again, this is another lower extremity arterial stent, nicely opposed to the arterial wall. This is a patient with a right popliteal artery aneurysm. You see the aneurysm wall, thrombus, and we see a lumen from within, okay? Again, another popliteal aneurysm, large thrombus, and this thrombus is certainly quite significant there, and you see the patent lumen. This is a patient with a stented popliteal artery aneurysm, and you see that the lumen hasn't fully thrombosed yet. This is a stent graft, okay? And again, you can see the echogenicity of the stent graft, and then the arterial wall is slightly calcified. This is a patient with a popliteal artery aneurysm. In this case, it's a little smaller than the other. You see the wall, and you see some of the intraluminal thrombus or intimal lining, gelatinous material, etc. Again, you see a popliteal aneurysm, slightly irregular, calcified wall, okay? And when you start seeing an aneurysm that's not completely thrombosed, you see sort of these more predominant or more prominent reverse diastolic flow, almost like you're looking at a pseudoaneurysm. It's just that the aneurysm, you start getting some recirculation. And we're going to get to that. Here's a patient with a very proximal anterior tibial artery aneurysm. So you look at the aneurysm, it's right there. This is that tibioperoneal trunk. The popliteal artery, of course, is more proximal. The vessel comes off. This is the first collateral. Sorry, the first branch. And then you see the aneurysm. There's the anterior tibial. So what do pseudoaneurysms look like? Well, to and fro. Here's a patient with a common femoral artery, and there's a very small posterior common femoral artery pseudoaneurysm, and you see the antegrade flow and the retrograde flow within that pseudoaneurysm. And here on power Doppler, you're able to see the area in question. Again, here's another patient with an anterior wall pseudoaneurysm. And again, you see these the to and fro flow within the aneurysm. And when you look at aneurysms, you always have to try to measure the neck length, the neck diameter, because it provides significant information, as well as the size of the pseudoaneurysm and how much thrombus is present. And these are some of the things that we look at pseudoaneurysms. Again, here's another example of pseudoaneurysm. You have the measurement of the neck length. We need the neck width, how much of the pseudoaneurysm is involved with thrombus. Again, the to and fro flow in a partially thrombosed common femoral artery pseudoaneurysm. Again, another example of a pseudoaneurysm. Here's the yin-yang color changes. Again, we talked about this a little bit, how the vessel tends to fill up with some material inside. You notice the graft is completely open. Material starts to fill in as you start getting down to fit the outflow that's diminished. Here's the patient with a PTFE graft. You see the various layers of PTFE graft with intraluminal filling defects. And again, this is also PTFE graft with rings. These little dots are the rings. Again, this is a patient with a stent, and there's some fluid, almost a seroma around the stent. I would venture that this is a drug-eluting stent, probably, which we have seen some fluid around stents. This is a Dacron graft. You see sort of the zigzagging appearance of a Dacron graft. This is a patient who has a chronic thrombus at a common femoral artery endarterectomy. It could be maybe a little intimal flap. On video, you could see it move. Very small. Again, here, this could be potentially a small dissection or intimal flap within the common femoral artery. You see that line sitting there. You see it there. There's no flow. And then you see color flow below. This is a patient with a superficial femoral artery, but you see the flow is completely disturbed. Very high flow velocities, very high diastolic component, completely disturbed. This tells you there's an AV fistula. And that's confirmed because you see the femoral vein. There's retrograde, high disturbed, high velocity disturbed flow. So there's an AV fistula between the common femoral the superficial femoral artery, and the superficial femoral vein. What do we see with heart failure? Notice cardiogenic shock waveforms. They look almost like pulsatile venous waveforms in a way, like sort of very disturbed waveforms. So low amplitude waveforms, you lose your phasicity. It's almost a biphasic waveform. Here's another patient with cardiogenic shock. Note the waveform in the popliteal, in the distal popliteal, on the right side and on the left side. Well, this looks like a more higher resistance, so I would venture that on the right side, the patient has a little bit of outflow disease, as this waveform is more resistant than the left side, which is the more normal side. Again, you see popliteal distal, posterior tibial. Notice the waveforms, very low resistance. So posterior tibial is open, peroneal, maybe hypoplastic or small in caliber because the waveforms are a little more resistant than the posterior tibial. Again, patient with a massive MI. There's definitely iliac inflow disease potentially. Could it be on both sides potentially? Or this could potentially be in the face of some disease, not very significant disease, but cardiac or pump failure. This is a patient in cardiogenic shock with Impella device. Remember, Impella device is not really a pulsatile waveform. So what you're going to see is almost like this VFib-like waveform. So if you didn't have the history of cardiogenic shock, you would think, oh, there's significant tibial disease, barely any perfusion. But because we see that there's toe perfusion, we know that this is essentially something else. And in this case, the clinical history tells you patient has an Impella device. Again, this patient has an LVAD. Notice the waveform appearance. You lose the triphasic waveform appearance. It becomes almost monophasic or biphasic at times. This patient is again on an LVAD, and again the waveform morphology, it's like you can't tell that there's waveforms. It looks like almost noise. Patient with an intra-aortic balloon pump. How do we know that? Well, we know by the history, and the other thing is you see this sort of elevation. So this is the peak systolic waveform from the patient's contraction. Then it goes back to normal. Where's my cursor? It goes back to normal. And then this little peak here, that little peak is when the balloon expands to get you that extra, more forward flow. And then lastly, this significant dip before, at the end of the diastole, right before the next systolic, is when the balloon deflates and you get, a big reversal of diastolic flow. Again, this patient is on ECMO. Notice that the significant diastolic component, some peak systolic waveforms in the common femoral. SFA is essentially occluded here, and then you get distal reconstitution of very monophasic waveforms, very high resistance, almost like a continuous venous waveform. This patient has decreased upstroke, rounded systolic peaks, low resistance appearing waveforms. This could be an aortic stenosis or cardiac pump failure. So my pearls are, and I know we covered a lot of material very fast, we have about 5 minutes left, is follow a protocol. Do it the same way every time. You find abnormalities, that dictates getting additional images. You got to look at it. You got to see, kind of try to figure it out. Don't just look at the numbers, because numbers can be normal, like we saw on the physiologic studies. But look and understand the waveforms. Personally, I think that the waveforms give you so much more ability. You can tell that there's a stenosis or not based on the waveforms alone. And then the velocities will help you determine how significant is it. Is it 50%? Is it more than 75%, etc. The other thing is, the more you read, the more you're going to be able to see, the more you're going to be able to understand the language that the waveforms are trying to impart to you or trying to communicate with you. And the better you get at it, the better you're going to be. You're going to be able to really read things faster and really understand better. Let me see if we have any questions now that we've completed our sort of more didactic version. And we'll take some questions from the audience if there's anyone interested in asking us. We have 5 minutes left so we can stay on time. I'm going to go back to the pearls section. And again, read a lot. If you find a waveform you don't understand, trust me, get online, look for articles so that you can really understand what's going on and try to find your way through sometimes this complex world of waveforms and physiology. It's been a pleasure being here today. If you have any ideas of other lectures that you would like to hear about as it regards to ultrasounds, please let us know.